Thank you. I'm Jody West. This is the final 10th and final session of this series of the Pediatric Mental Health Tele-Echo session for PPCL. I want to welcome everybody to this session. If you want to go ahead and put your information into the chat for attendance, and also to send information to you post, including the slides and any recommendations for the case presenter, and the survey for any continuing education needs you might have. But this is the agenda today. We're going to do our best to stick to it. It goes by pretty quickly. So I'm just going to go ahead and move forward with this. I am the coordinator, so I will be behind the scenes promoting the slides, and Dr. Olivier is going to facilitate the overall discussion of the presentation. Dr. Roy has joined us and graciously agreed to present the didactic today. And then Lena, who is a member of our hub team, is going to present a case of one of our consultation requests that have come in. And then there'll be time for questions and recommendations. And then we'll wrap up and have announcements for the next session. So I'm going to introduce myself again. I'm the coordinator for the ECHO, but I'm a program manager for the provider-to-provider consultation line. We provide no-cost statewide mental health consultation for pediatric and perinatal mental health concerns to primary care providers as well as other professionals. So we work directly with providers, and we don't take over the care of your patient or client, but we can assist you with finding resources, discussing therapy options, and connecting you to a psychiatrist should you want to discuss medication or in-depth diagnoses. So I'm going to leave this screen up there, and if you scan that, you can get more information about PPCL and get program information. And I'm going to pass it to Dr. Olivier to continue with introductions.
Hey, good morning, everybody, and welcome back to our last pediatric echo session. Again, I'm Dr. Olivier. I'm a child and adolescent psychiatrist here in Lafayette. I work in private practice, and I'm also the facilitator for these echo sessions. So I'll be facilitating discussion and hopefully making sure we run on time. I'm going to ask our hub team of experts to reintroduce themselves to everybody, starting with Dr. Queen.
Hi, I'm Dr. Katie Queen. I work for Our Lady of the Lake Children's Health, and I'm a practicing general pediatrician and obesity medicine specialist, and I'll be kind of behind the scenes answering questions and helping out with the pediatric side of things.
Thank you, Dr. Queen. How about Ashley Hutchins?
Hi, I'm Ashley Hutchins. I'm a psychiatric nurse practitioner at Bloom Mental Wellness here in Lafayette, Louisiana.
Thank you, Ashley. And you've already met Jody West, our program coordinator. And so for about the next 20 minutes, I'm going to turn the floor over to Dr. Cody Roy, who is the program director for the Child and Adolescent Psychiatry Fellowship over in New Orleans, Louisiana. I'm excited to see him present. He has a beautiful PowerPoint. We'll see how the content is by the end. But he's presenting on a great topic, pediatric behavior problems. Is it a psychiatric problem or something else? So go ahead and unmute yourself, Dr. Roy. You could have the floor.
Thank you. Thanks for having me. I always like doing these talks. Please cut me off if I talk too long, or add some content if I go too short. I do like to take questions or thoughts, and I think this is a fairly unremarkable but provocative, I know that sounds a little contradictory, topic. My dearest friend from medical school, I just met with him a few weeks ago in Seattle, and he told me, Cody, I'm quitting being a doctor in April. And I said, oh, can you do that? I didn't know that was possible. He's a family medicine doctor, and he said, I've had it. I've just had it. He said the final straw was when his organization said, those patient messages we can get in the portal, they now allow patients to mark them as urgent, and you have 3 hours to respond to them, night or day. And he said, that's it, I'm out. And then burnout's been a big topic, and I have this soft spot in my heart for primary care providers who are being asked to do everything under the sun. And now, as part of ACGME requirements, pediatric residencies, as I understand, have to have child psychiatry training as well. So everybody's sort of scrambling to add more things for y'all to do. So my secret agenda today was to sort of relieve you the burden of feeling like you have to solve psychiatric problems, or even that you can. Most of the time I can't anyway. So that's what this talk is kind of about. Let's see. Oh, I can't move the slides, so I'll just say next, I guess.
Yeah, I'll do the slides. If you want to just give me a verbal cue, I'll go ahead and promote when you're ready.
Verbal cue.
Yeah, like next or okay.
Oh yeah,
or-
next. Yep.
Thank you.
There's this idea that we're in a mental health crisis and that pediatric mental health problems are on the rise. I don't really know what that means. I know people like to say that a lot, especially when it's tied to funding, but it's sort of unclear exactly what that means, although we all tend to nod and agree and say, yes, that's true. Actually, if you can go to the next slide. This is hot off the press from the CDC 2024 that they say kids, and I'm not sure the exact ages they're including, I think it goes up to 15, 35% of them have stress-related health issues now. So actually, stress-related health issues seem to be more prevalent than psychiatric issues. And actually, self-reported depression and SI has been going down over the last couple of years. I think probably that's because there was a bump up in the pandemic. But threat and violence, bullying, problematic electronics use are on the rise. So I think what's going on is that kids are getting more and more stressed, and there's more and more external factors acting on them and families. I don't know necessarily if that means there's more prevalence of psychiatric diagnoses or not. My guess is that stress doesn't always translate into a diagnosis. Next slide, please. There's all kinds of problems that kids present to my clinic with. Not being able to get along with your parents is not a psychiatric diagnosis. It's not part of any criteria for a diagnosis that I know of. Not wanting to go to school similarly, having tantrums just at home, getting busted with weed, anger issues. None of these are symptoms of a psychiatric diagnosis necessarily. It's kind of easy to approximate ways that they might be and sort of shunt them into kind of an algorithmic medical model thinking. But these are just problems that kids have. And so I think one of the challenges that we run into is when these presenting problems come to us, that we maybe over-medicalize them or try to chase down a medical route. And I think that's what's leading to this sense of burnout, the sense of inefficacy, the frustration with trying to treat mental health problems, is that we're inappropriately trying to shunt them into diagnoses. Next slide, please. This is very hard not controlling my slides. This is a good exercise for myself. It's like a mindfulness exercise. The chief complaint in 105% of kids that I see is behavior problems. This is sort of the only chief complaint ever for pediatric psychiatric issues, and they come in different flavors and varieties. Next slide, please. So, of course, if we dissect this or do a little bit more nuance, it can be things like, oh, they talk back, they won't listen. Sometimes it's he gives up on his work, he's not motivated, or he's mean. What does that mean? Manipulative. I hear that a lot. I'm never really sure what that means. Usually it means they're clever and they're trying to get resources that they should be getting otherwise, but they refuse to do what I say, and they steal, these kind of things. Next slide, please. So this kind of collection of things that we call behavior problems, which are usually the chief complaint in pediatric psychiatric problems, can be explained from a lot of different perspectives. Next slide. So we can use a medical model to explain them, and usually that comes in the form of diagnostic language. So we might say, oh, perhaps this cluster of problems is explained by ADHD. None of these are symptoms of ADHD, but we make these sort of approximations. Or maybe this is explained by oppositional defiant disorder, a conduct disorder, or an anxiety disorder. So that's one way to try and understand behavior problems. What's the next slide, please? We can understand them from a developmental perspective. So we might say, well, that's this child's temperament, or there's, sometimes we use the term, a goodness of fit problem between parent and child, disrupted early attachment. So it's another way to describe these problems. Next slide. Probably the most common, or the most common reason for behavior problems are just functional things like being on the cell phone till 2 a.m., 8 nights a week, a disorganized household. Nobody knows what the homework assignments are in the house because no one's bothering to check with the teachers, these kinds of things. This can be a cause of behavior problems. And then next slide. And then lastly, is it normal? Is this really pathology, or is this the way any child who's grown up, in a resource disadvantaged environment in 2024 with this incredible amount of external factors on them would behave? So is this not just normal behavior in what's sort of a non-nourishing environment surrounding the child? Next slide. Do harm. Do no harm. The slide didn't translate into a PDF, but this is part of our training in medicine. We have different sort of ethical guidelines and principles that we follow, and one of them is to do no harm. And sometimes taking behavior problems and sort of running in a medicalization direction can cause more harm than good. It can cause overt harm by giving medicines, diagnoses, interventions that may cause problems or side effects. But also there's an indirect harm in that we're not naming the actual challenge or problem, or we're missing things. A common example would be like a young kid who's saying they're hearing voices and seeing things that might get started on a neuroleptic because we're trying to do a thing for a diagnosis that probably isn't there, and we're missing other things like bullying at school or stress at home or insomnia or these kinds of things. Next slide, please. So here's some just hot tips on behavior issues in kids that I think are really important, that I think can help us just feel a little less tense about the idea that we have to solve these things ourselves. The most common explanation for behavior problems in kids is no diagnosis, or is not a psychiatric diagnosis. So we don't have to go hunting for diagnoses. We don't have to direct the interview narrative into diagnostic language. In psychiatry, we use biopsychosocial ideas, meaning that any presenting problem that a kid or family brings to us, we want to think about from multiple perspectives. Biological, of course, would be things like genetic contributions, if there's been head injuries or medical issues. Psychological would be sort of what's going on in the mind of a child. So we might think about cognitive distortions or even just their relationship to their parents. And social would be everything outside of the kid that could be contributing to the behavior problem: poverty, lack of access to resources, parents who are struggling with substance abuse problems. And what we know in child psychiatry from the epidemiology is the younger a child is, the more likely that their disturbances are caused by external factors, social factors, those sorts of things. So that the social component is really the best explanation for problems in children. Even when a kid meets criteria for a diagnosis, treating the symptoms themselves, in peds anyway, is rarely that effective. So people who are treating kids probably have seen this, that most of the problems, the reason that people seek care is not for their symptoms. Like if I'm going to go see a therapist or counselor, I'm not going to say, oh, hey, I'm Dr. Roy, and I'd like to start therapy so that I can have a 50% reduction in my self-reported PHQ-9 score, right? No, I'm going there because, I hate my job, my marriage isn't going well. There's some kind of problem in my life. And same with kids, when we are treating a diagnosis, what I find is that's sort of a road to burnout, because people get a little better, and that leads to lots of messages in your inbox like the medicine's not working. Well, of course it's not working. It wasn't really designed to work for that problem. And then what I suggest is that we should aim to solve functional problems, practical problems. A kid might be coming in. I saw someone this morning who was coming in for symptoms of ADHD, but the reason he was brought in was because if this mom said she was going to lose her job if she had to come one more time to pick him up from school. That's the reason she's seeking care. And so the most effective treatment plan is one where we prevent mom from losing her job. A portion of that might be helping her kid be less dysregulated in class with the use of a stimulant, but that's not the sole treatment plan. And when mom can understand that's just a component of it, she's less likely to call me to say the meds aren't working because she knows it's only supposed to work for the small part of it. It's not so it's sort of contextualizing treatment around a problem I'm trying to help you solve. Next slide, please. I know I'm just kind of rambling. Any thoughts or questions? Do we take thoughts and questions? I don't know. Or we save them till the end, I guess.
Save them to the end.
We'll save them to the end. I saw a kid a few weeks ago. He's 12. He looks like he's 25. He's an inch taller than me, and I'm 6'3". He's got a mustache. His mom brought him in for delinquent behaviors. He's been in 2 alternative schools. He's in and out of regular classes. He's been caught with a vape. He's been hiding and helping the older kids sell vapes. So he's kind of like the vape mule and not real motivated for school. Probably doesn't have a super high IQ. And mom's coming to see me for help. And so already there's been this decision point that there's some medical intervention for this, right? She didn't take him to see a priest or to go talk to the football coach or any other number of possible places she could have taken him. She's coming to see the psychiatrist, which means there's some sort of thing wrong with the child, and my role or our role is to try and fix that. And so, we can go sort of down a medical algorithmic route. And I think this is what causes us to burn out and get stressed out, is there's no diagnosis that's going to solve this. If I think, oh, his motivation's low and he's not engaged, maybe this is major depressive disorder. Well, that doesn't really line up with 12-year-olds, but sure, say I treat him with an antidepressant. Probably that's not going to improve this 12-year-old's motivation to do well in school when what he wants to do is hang out with the older kids and be hustling. I could say, oh, maybe he's struggling in school because he's inattentive and hyperactive. Similarly, a stimulant will help him sit in his seat, probably not going to motivate him to act right as mom's hoping will do. So again, following a diagnosis, I find is not all that helpful. In this case, we kind of framed it around just development in the sense that here's somebody who's at a different developmental stage than his peers who are, going through identity versus role confusion, and he's still in industry versus inferiority, or he's at a different developmental state. So there's this mismatch, but he wants to hang out with the cooler kids because physically he's much bigger, and what he enjoys to and what he gravitates to is hustling, which, I think if kids are watching lots of social media and YouTubing, that's what kids are doing. They're hustling, right? They're influencing, they're trying to. And so what I suggested to mom is we need to come up with a plan where he can still feel like he's connecting with the older kids, where he can still feel cool, where he has some way to hustle, but that isn't illegal and getting him kicked out of school. And that was our treatment plan. And I said, Mom, go forth and figure that out. You tell me what you found. This isn't the first time I've done that. I've done this with other kids who are interested in art but not doing well in school. And one of the parents found a tattoo internship. And once the kids can gravitate towards something or hook into something, we find a lot of these behavior problems kind of dissolve or melt away. Next slide, please. Oh, this didn't come out exactly right either. But so I think in terms of what do we do when kids are presenting with psychiatric or behavioral problems, number one, we have to trust that parents can solve these on their own, and that we're not going to be able to solve it for them. We don't live with them. We're not seeing the nuance. We don't know all the details that they're leaving out. So our job is to just give guidance and recommendations. And 90% of the time, if parents are going to follow them, that's going to solve the behavior problems. If they're not going to follow them, you couldn't help them anyway, even with, there's parents who I've met with multiple times to develop the most sophisticated token economy system at home, but they don't do it, so the kids don't get better. So there's a few very high yield challenges that are going on right now that I think are leading to behavior problems in kids. And Jody, can you go ahead a slide? I just think these just didn't copy over to PDF. Yeah, this is fine. So number one is this whole world of electronics is creating a lot of what look like mental health problems in kids for various reasons. I think it's pretty safe to say that there's addiction issues now with reward in the brain. The sort of fast reward that's embedded in social media scrolling, as well as a lot of the video games, seems to be making it harder for kids with ADHD to sustain attention. And also when you're doing electronics, that's just time you're not doing other stuff, right? That's time you're not involved in extracurriculars or socializing IRL with people or getting your homework done, or even just having a conversation with your family or chasing the cat around, whatever. This is the next one we don't talk a lot about, but I see this frequently as disorganized and chaotic households. Is a lot of times if we trace behavior problems back to just tell me your schedule for the day, what we find is just it's the Wild West at home. Kids get home anytime between 3 and 9 p.m. There's sort of no rules until the parent, discovers no homework's been done at 11, and then there's yelling and screaming, and meals are just kind of eaten whenever, wherever. And so sometimes just sort of circling back to a plan where we just got to get ourselves organized can ameliorate a lot of behavior problems in kids and prevent them from getting psychiatric diagnoses, which often don't help anyway. Sleep, I've just stopped asking about it and just assume every kid has sleep problems now. It's such a common problem, and it seems to be related to a number of factors, electronics being one of them. But that's kind of low-hanging fruit that if you solve or work on, a lot of these kids now are even as young as 6, 7, 8 or up till 1, 2 a.m. regularly on school nights. So I just I don't even want to know anymore. But they should be getting 9 to 10 hours a night at least. And so sometimes correcting that in and of itself has helped with behavior problems. And then this last one, being disconnected from school. I'm surprised how many parents don't know the name of the kid's teacher, don't really know if they have homework or not, don't know what their grades are, have tension themselves between the school. And this can create a lot of things that look like behavior problems in children when there's a bad relationship and when families don't really have boots on the ground and understand what's going on. So I think if I were a primary care provider or a physician who was taking care of kids presenting with mental health issues, I think the highest yield is just be familiar with resources and to be able to identify these common problems rather than diagnoses. Next slide, please. And thank you. So there's parent programs. These are the ones I've just been using them for years. They work great if you do them. 1, 2, 3 Magic is for behavior problems and how to talk so kids will listen so kids will talk is a good resource for communication and relationship related issues. And I have no problem recommending a book because, most of these parents say, I'll do anything for my kid. And they'll say, well, could you read a book? And, well, I didn't mean everything. But the truth is, if you're not, if you can't read a book and carry out the basics of a program, there's nothing I'm going to be able to do to help you anyway. I use a lot of cell phone contracts, and Jody, if we want, I can send you the one that I use. This is a contract where parents and kids who have a phone choose what they want the rules to be. They both mark them on a list. Everybody signs it. It's clear what the penalty will be for violating it. You stick it to the wall, and then there's no arguing about you said this or I said that. And that helps alleviate a ton of behavior problems that are related to cell phones. Just everyone being on the same page about what the rules are, rather than making it up every time there's some violation. Common Sense Media is a website y'all are probably familiar with, but you can direct parents to it. It will give you ratings and different descriptions. There's so much electronics out there, it's hard to keep track of as a parent. And then just knowing something about sleep education. How do you move a kid's bedtime from 2 a.m. to 9 p.m., sort of slowly. How do you time the medicine for that? When is melatonin useful? When is it not? So I think knowing this stuff is as or more valuable than being able to recognize psychiatric diagnoses and how to treat them. I think you get more bang for your buck. I think it's higher yield. And the truth is, if you're really getting into the weeds about diagnostic clarity, probably we have to be referring anyway. Next slide. Not that there's anyone to refer to in Louisiana, but. And I just want to point out that this is all under the umbrella of what I would consider psychoeducation or just education for families. And there's a lot of literature, and the body of it's getting more and more and more, that psychoeducation is as or more valuable than any kind of individual therapy. So people that participate in CBT or people that got just psychoeducation seem to do equally well. And so we don't always need to sort of refer out to specialists. And again, in Louisiana, it's hard to find specialists anyway. And so don't underestimate the value of psychoeducation with parents. In my office, I have I have crayons and paper here, and I'm just drawing like, here's your brain, here's ADHD, here's a go forth, or here's a schedule for the day. And people follow it and they bring the drawings back, they take photos of it. So I think if we're motivated to help them solve a problem practically, parents listen. Next slide, please. I don't know. I think people get anxious when I don't talk about medicines. I think medicines are useful regardless what the diagnosis is, when problems are persistent, pervasive, and they're preventing families from carrying out these practical plans. If a kid's so dysregulated that a family can't put a schedule into place, if a kid's so dysregulated that they can't enact a cell phone contract or something like that, then that might be a time to kind of use medications as an adjunct to solve these sort of external factors. Next slide. This is probably not interesting to anybody, but there aren't many medicines anyway. Some of the more common childhood diagnoses that we associate with significant behavior problems are ADHD and autism, and here's some of the medicines we use for it. So maybe y'all got this earlier in the year, but I just wanted to put it out there. Next slide. So when I think referring to, again, most of these problems I think can be solved with some just sort of support and psychoeducation. If there's safety concerns, if a child's deteriorating across multiple areas, school, friendship, home, extracurriculars, that might be a time to refer. If you need a second opinion on an existing diagnosis, I think that's a great referral. If some kid comes to you with a bipolar diagnosis and you're not feeling confident about that, I think that's a good time to lean on this service or to send for a psychiatry, or multiple morbidity, really complex kinds of cases. Next slide. In summary, social, economic, and other stressors are on the rise. I think that unfortunately that's getting shunted into being called mental health problems, which sort of that is one of the many downstream effects of it. A strained stress environment raises kids that are strained and stressed. So we shouldn't think of all these kids as pathological. We think of them as adapting to a stressful environment. We want to be careful not to medicalize behavior problems, and medicalization treatments aren't that helpful anyway in psychiatry, especially in the pediatric population. Sleep, electronics, and disorganized homes are what I'm seeing. And I've calculated now I've seen about 8,000 kids and families. And these three things are constantly seem to be the context in which these behavior problems are emerging. Psychoeducation, and then try to manage or refer if you can. So that's the end of my slides. Thank you.
Thank you, Dr. Roy. I think we can use a couple minutes for questions because we have a shorter case today.
Okay.
So anyone have any questions? You can use the chat or unmute yourself and just chime in.
I have a quick question, or maybe not quick with anyway. How do you bring up the topic that maybe it is the home environment and working toward that the parent having to do the work as opposed to a pill?
Yeah, depends on my mood that day, to be honest. I think there are certain places that you can always start with somebody, which is we can all agree that this is stressful as hell. And most parents already know that there's things that could be going different. I think, it's different for everybody, but always starting from a place of this has been thrust upon us. Like the biggest one is this electronics talk, as I always start with, none of us wanted this. This was thrust upon all of us. None of us know what the hell we're doing. What's working for you? What's not working? Here's what other parents are doing. sometimes a little bit of displacement. I just saw a kid an hour ago who'd been having the same problems. And although it was hard, their family, got a dinner and homework scheduled together. And they told me this, that their symptoms improved. Is that something y'all would want support with? So I think working the best we can to eliminate any blame language, and also just recognizing, these aren't bad parents. We're just living in a chaotic, stressful world and economy. So I think if you approach it from the perspective as the parents are victims at some level too, the language tends to follow. And honestly, a lot of the families that I see are not coming to look for medicine. Somebody's told them to come. The school's told them to come. A neighbor told them to come. So it's very rare that I see people that are in here like demanding medicines for their child, especially in the community I work in. But yeah, I don't think there's any one good way to broach it.
Just to follow up, I'll be frank, in where I'm working, and Louisiana is not the only state I have worked in, but this is a state where I don't find, I'm not going to say the majority, but there seems to be a disconnect between understanding how the home life affects things, how the parents' behaviors affect things, and then almost making the child an adult with adult thoughts and actions. So like that whole manipulation. I mean, I've heard that language applied to 3 and 4-year-olds. So I'm being serious now, like my face, but like when I get that, I do have to laugh, because then I have to wonder, what am I going to go into? Like, what is the expectation here? So I ask it in full seriousness, because, it's not an electronic thing, because sometimes they can't afford electronics for the kids. That's not an issue. It's a chaotic household. And trying to bring up like, okay, where can we make changes? Sometimes it's even the recognition that there's a psychological thing going on. And some of it, and you're right, psychoeducation would be helpful. I don't even know where to begin to refer, or even, education wise, a book wouldn't do it. I'm sorry. And I'm not, and I know those books too. Like I've used them, but
what I'm saying is, if that's not going to work, there's nothing you're going to do that's going to work management wise. And so that's kind of the overall point I'm trying to make, that trying to then twist that into like, well, maybe if I treat it as ADHD or this and that and the other. So sometimes I approach difficult cases just like I would if I were a cardiologist. I'm about to show how little I know about cardiology. Here's your x-ray, ma'am. But you've got blockage in this vessel. Here's what you need to do if you don't want to have a heart attack. Right? Sometimes it's, your child's having these problems. You got to get your home organized. That's people deserve to at least be told that here's what the solution is. Even if we don't think they're going to do much with that information.
I think that is about all the time we have. Sorry, y'all, for questions. We have to move into our case presentation. Thanks again, Dr. Roy. Thank you, Lena, for presenting. I'll turn it over to Jody for wrap up and announcements.
Thanks to everyone. Dr. Roy will send, ask that you send the cell phone contract, and we can send that out with recommendations too as an attachment. But make sure that you enter your information for attendance. In the chat, there is the survey link for continuing education credits, but we'll send that out in an email as well. We do not have any more scheduled at this point, but our fourth pediatric mental health tele-echo series will start in February. So we'll send that information out in our newsletter as well as to all of the participants. It will look different next year because there is a different system that Project Echo is using. So it will be different than what we've utilized up till this point, but we'll make sure to send instructions to everyone in that way, and be available for questions and problem solving. It is easier than what we do now, for participants as well as for us that are hosting it. So I look forward to seeing everyone in February. Please reach out if you have any questions and look for that email by tomorrow with the recommendations, the slides, and the survey link. So have a good afternoon, and thanks to Dr. Roy and for Lena, as well as to the Hub team for all of your work that you've done. And we appreciate everyone's attendance, and we hope to see you for our next series in February. We'll stay on for a few minutes if anyone has questions, but enjoy the rest of your
I'm going to try and drop the cell phone